okay, sa mga patients nyo, no? Because kailangan talaga yung confidence. Yun yung isa sa mga reason bakit mababa ang use of IUD, even if we know that it has longer effectivity, no? And it's readily accessible kasi of the confidence of the provider. Okay? So, next is how do we manage these complications, no? For patients with severe pain in the lower abdomen, you have to rule out PID, ectopic pregnancy, or perforation. Okay, if PID is suspected, treat with appropriate antibiotic, no, like your gonorrhea, chlamydia, and anaerobic coverage. Okay, and there is no need to remove the IUD. Okay, so hindi yan next best step for patients with infection with intact IUD. Okay, do not remove the IUD, treat the infection first, ask your patient to follow up. If persistent, then that's the time you remove the IUD. Okay, now for suspected perforation, while inserting, of course, you have to stop the procedure immediately and remove the IUD. Observe vital signs every 5 to 10 minutes for an hour. Okay, and if na-resolve siya, no, then you can advise your patient alternative contraception and avoid sexual intercourse for 2 weeks and follow up in a week or as needed. Now, if you have patients with missing strings, no, nocturnal routine ba na kailangan i-IE or mag-check yung ating mga patients, no? Advise them to check. Well, it actually depends on the patient. Wala namang sinabi na every month dapat nag-check ka. Okay, but if there are symptoms like foul smelling, spotting, okay, a suspicion of pregnancy, then that's the time you do talagang mag-IE ka. Pero we can advise them, no, syempre to clean their hands and then try to feel for the string. Okay, pero hindi naman kailangan lagi-lagi yan. Okay? So if there is a missing string, the first step or the next best step there is to determine the risk of pregnancy. Okay, so perform pelvic exam, probe for the strings in the cervical canal. Okay, now how do we probe it? Ideally, meron tayong thread retriever, no? Pero wala tayo noon. Wala pa akong nakikita actually. But we can make use of your cytological brush, di ba? Yung may mga arrowhead na yung plastic, no, na ginagamit natin, no? And then twirl it within the endocervical canal to entangle the string and bring them gently into the vagina. Okay, if hindi kaya, okay, or if there is resistance, then do not force. Okay, if you cannot locate the string, consider X-ray or ultrasound and give choice of another contraceptive method. Now, if natanggal nyo and sure kayo, napakita nyo, complete yung inyong IUD, then you can insert another IUD if she likes and she doesn't want to get pregnant yet, no? Or if you can offer her other available methods. Okay? Now, for suspected pregnancy, of course, you have to assess for pregnancy, including ectopic pregnancy. If the client is pregnant and wishes to continue the pregnancy, you have to be able to explain that an IUD in the uterus during pregnancy increases the risk of preterm delivery or miscarriage. Okay, now when is the best time to remove that IUD in a pregnant patient? No? Wala kasi sa literatures. Sa ating Williams Gyne, no, na libro, nakalagay doon is at least 14 weeks. Okay, but you have to explain to your patient, you have to counsel, share decision making that there is a small risk of miscarriage. Okay? But never attempt to remove pag hindi yun nakita yung string, ha? These are for IUD in pregnancy na visible yung string. Okay? You have to have a shared decision making. Okay, whether the IUD is there or matanggal siya, there will be risk of miscarriage. Okay, and also advise close follow-up for signs of septic miscarriage. Okay, now for patients with vaginal infection with IUD intact, of course, you have to do speculum exam, look for the string, rule out sexually transmitted infections and other vaginal infection, and treat the infection. Now, if the patient wants to have it removed, then you can remove the IUD, no, and start antibiotic and offer other methods pag ayaw nyo pang magbuntis. Now, if the patient wants to continue, do not remove the IUD. Now, treat the infection. If persistent, then that's the time you remove the IUD and offer other FP methods. Okay? So, ang unang ano pa rin dyan is yung desire ng patient. Okay? Kapag gusto niya, kahit na-counsel mo siya na pwedeng huwag mo nang tanggalin, treat the antibiotic, pero gusto pa din niya, then you can remove the IUD and offer other FP methods. Okay? Next na effective for postpartum patients would be a progestin subdermal implant. Okay, so when you do tiering of effectivity for postpartum patients, the long-acting reversible contraceptives ang una. Okay, so progestin subdermal implant contains your etonogestrel for your single rod at 68 milligrams or for your double rods, sorry for the typo, it contains 150 milligram for both. So 75 milligram levonorgestrel each rod. So dalawang rod would be 150. Okay, dalawa na po ang locally available natin. The single and the double rod, etonogestrel containing and levonorgestrel containing respectively. Now, what would be the mechanism of action? The implant inhibits ovulation, okay, which is the primary effect, and it thickens the cervical mucus. Okay, so dalawang effect niya. So after removal for both eto and levonorgestrel, there will be decline to undetectable level within 1 week. Okay, that is the advantage of these implants for patients na gusto ng rapid return of fertility. Okay, once you have removed it, okay, within 1 week, undetectable na siya. Within 48 hours na theoretically okay, there will already be resumption of ovulation. Okay, but ovulation resumes 1 month after removal, 90%, and bleeding irregularities is the most common reason for discontinuation. Again, because it only contains your progestin na hormone. Okay, so meaning maintained, na thinned out ang lining ng patient because you don't have the effect of estrogen, which causes rapid proliferation of your endometrium. Okay? Now, with progestin-only injectables, no, effective din siya for your patients na postpartum. Okay, we have your 150 milligram of medroxyprogesterone acetate in a microcrystalline solution administered intramuscularly every 3 months with an effectivity of 99.7% with perfect use and with typical use of 97%. It is effective because it also has good benefits, meaning okay siya for breastfeeding patients. Okay, however, for progestin-only injectables, according to WHO FP Handbook in 2022, it can be given only as early as 6 weeks to 6 months after. Okay, for progestin-only injectables to for your contraceptive implant, for your progestin-only pills, pwede siya immediately prior to discharge. Okay, so as early as 6 weeks to 6 months after, okay, pwede siyang ibigay. Now, for postpartum and non-breastfeeding clients, you can give it immediately or at any time in the first 21 days after childbirth. No need to wait for menses. Okay, or after 6 weeks, anytime the patient is reasonably certain that the client is not pregnant. Okay, now especially for our adolescents, less than 16 years old, no, and our extreme of ages, perimenopausal patients, no, ang isang concern nila with regards to progestin-only injectables is the effect in the bone mineral density. Okay, remember before meron tayong black box warning, but it's already lifted. And when you look at the studies in that black box warning, mostly RDMPA yung ginagamit nila doon sa studies na yun. No? But they have already lifted. Bakit ba? Ano ba yung problem nila with regards to bone mineral density and progestin-only injectables? It's actually the decrease in bone mineral density because of the absence of your estrogen. We know so well that estrogen has benefits or beneficial to the bone because it inhibits osteoblast apoptosis and increases osteoblast lifespan. And also, during bone growth, estrogen is needed for proper closure of epiphyseal growth plates, both in females and in males. That's why for your patients less than 16 years old, progestin-only injectables is categorized as category 2 in your medical eligibility criteria because of this concern. No? So yung full potential of bone growth is mai-impede because of this. Okay? Now, if there is estrogen depletion, okay, remember again that apoptosis is regulated by estrogen. So with estrogen deficiency, the osteoclasts live longer and are therefore able to resorb more bone. And in response to the increased bone resorption, there is increased bone formation and a high turnover state will develop, which will eventually lead to bone loss and perforation in the trabecular plates. Okay? However, a lot of studies already have shown that the effect on DMPA on bone mineral density is reversible. Meaning once you discontinue the DMPA, babalik na agad yung bone mineral density nila. Okay? But for high-risk patients, no, like your perimenopausal with the calcium deficiency or with osteoporosis risk, you have to be able to evaluate them first before giving progestin-only injectables. And you can add calcium supplement for them. This is for high-risk patients. Okay? For low-risk, hindi naman necessary. Okay? Now, question number 5. A breastfeeding patient on progestin-only pills missed her linestrenol pills few hours ago. So, how many hours is considered as missed pill for her? Okay, this one is understand type of question. 3, 6, 9, or 12?
12 ako, 12.
6. Hi! Oh, so excited.
Okay, wait lang.
Same. My God. Mas feeling mong bobo ka pag nandun ka na.
Oh my God.
Okay, sige, let's take a look at the answers. So mostly, iba-iba yung sagot. May A, may D, may B.
Ang bigat. Hindi nawawala yung charger kung pares tayo.
Okay, so
Yung
when you talk about progestin-only pills, you have to know the component. Okay, because remember that for POP, napaka-importante ng compliance.
kasi yun yung
Dapat
biglang
dyan,
may code si
the same
Tapos hindi ko
time.
na alam sa
Okay, but when we advise our patients, at same time na lang across the board, meaning even your combined oral contraceptives. But very important for your POPs, ang timing. Okay? Okay, so progestin-only pills, also called mini pills. Okay, it contains norethindrone only, desogestrel only, or your drospirenone only pills. Okay, so for norethindrone, it contains 0.35 milligrams of hormone, and it is taken daily and continuously. Okay. The efficacy of this norethindrone stems from cervical mucus thickening and endometrial atrophy. Because mucus changes are not sustained, these pills are best taken at the same time each day. If the pill is taken every 3 hours late or missed pill window, a backup form of contraception is used for the next 48 hours. Okay, that is why, again, it's very important. Again, for norethindrone, the missed pill window is 3 hours because ang kanyang efficacy is from cervical mucus thickening. Okay, so pag nawala na sa bloodstream ang norethindrone, then pwede nang mabuntis ang patient. Now, with drospirenone, it contains 4 milligram taken daily for 24 days. 24-hour missed pill window. It is similar to your spironolactone, which has an anti-androgenic, anti-mineralocorticoid, and anti-aldosterone. Okay, the progestin withdrawal during the last 4 days aims to minimize irregular bleeding. And it reliably inhibits ovulation and alters cervical mucus and endometrium. Okay, so maganda sana to, kaya lang wala tayong locally available in our country. Okay, because again of the inhibition of ovulation. Okay, now disogestrel, okay, only, which suppresses ovulation and thickens cervical mucus to impede sperm penetration, has a 12-hour missed pill window. So both drospirenone and disogestrel has effect on the ovulation. It suppresses ovulation. Okay, it is a 28 pill preparation taken daily. Okay, but again like what I've mentioned, across the board, mas maganda same time na lang ang advice natin. Okay, kasi mahirap magsabi na ito pwedeng hindi, no, or ito dapat buong same time. So mas maganda na across the board ang advice is same time. Okay? So for linestrenol, 3 hours ang kanyang missed pill window. And for disogestrel, 12 hours. Okay? So in our country, 28 pills na disogestrel and linesterol ang available. Okay? So again, like your combined oral contraceptive pills, very important ang compliance. Okay, that is why for postpartum patients, no, medyo kailangan advisean nyo talaga sila. Okay? So now what will be the side effects, no? Irregular bleeding, headache, bloating, acne, and breast tenderness. Okay? Now when do we initiate? Madali lang tandaan. Okay, pag POP, immediately you can give it anytime between giving birth and 6 months, no backup method. Now if it has been more than 6 months after giving birth, monthly bleeding has not returned, she can start POP anytime. Okay, and needs a backup method for the next 2 days of taking pills. Okay, again, kapag breastfeeding more than 6 months and bleeding has not returned, pwede siyang uminom anytime, pero may backup method. And when you say backup method, condom or pills. Condom or abstinence. Okay? Now, if not breastfeeding less than 4 weeks after giving birth, pwedeng magbigay, no backup method needed. Pag more than 4 weeks after giving birth, bleeding has not returned, she can start anytime. But again, backup method is necessary. Okay, I hope okay pa tayo, no? Sige, let's proceed now with hormonal contraceptives, including your combined and your progestin only. Yung progestin only na-discuss na natin. Okay, so combined na lang tayo. Okay, so question number 6. The following are effects of ethinyl estradiol in contraception except A, stabilizes the endometrium, B, decreases tubal peristalsis, C, potentiate progesterone, and D, increase progesterone receptors. So what's the answer? Let me see. 9:03 na pala. Ang bagal ni Doktora. Sobrang bagal ko ba, Sir Ras?
Para take your time.
Okay. Sige. Meron pa akong 60 slides. Okay. So, hormonal contraceptives specifically combined contains your ethinyl estradiol and progesterone. Okay. Progesterone is the naturally occurring in our body. So, what we use is progestin, which is the synthetic form. Okay. So, when you talk about contraception, progestin dapat yung term na ginagamit natin. The main mechanism of action is inhibition of ovulation. Okay, the progesterone suppresses LH, thereby preventing ovulation. And the ethinyl estradiol prevents follicular stimulating hormone, which will prevent follicular growth. Okay, because follicular growth is important because if you remember your micro, there is conversion of androstenedione to estrogen, okay, or estradiol sa inyong granulosa cells. So pag walang follicular growth, walang ovulation ang mangyayari. Okay, also, progesterone action takes precedence over estrogen It makes the endometrium not receptive. The cervical mucus becomes impervious to sperm because it becomes thickened, and there is decrease in tubal peristalsis. So ito yung except dun sa ating tanong kanina, because estrogen stabilizes the endometrium, potentiate the action of progesterone, and increases progesterone receptors. Okay? Now, when we talk about combined oral contraceptive, marami tayong formulation locally available. Okay? So, when you provide combined oral contraceptives, it's very important that you also look into not just the contraception, but also its non-contraceptive benefits. Okay, for example, patient coming in wanting contraceptive but also has acne, for example. Okay, or also complaints of dysmenorrhea. Okay, so yun yung mga mas magandang tinitingnan natin also. Okay, this is also will increase the compliance of your patients. Okay? So, what are the types of our oral contraceptive formulations? Napag-usapan na natin yung progestin only or what we call the mini pills. Okay? But for our combined oral contraceptives, we have fixed dose or monophasic. Yan ang locally available in our country. And we have your multiphasic combination pills. For your fixed dose or monophasic, it contains tablet with the same dose combination of estrogen and progestin each day. For our multiphasic combination pills, the pills contain several different dose combinations that comes in the same pack. Okay, so pwedeng for the first 21 days iba, or for the first row iba, and 2 and 3 rows iba din. Okay? Now, locally available preparations. Meron tayong 28-day preparation. Pwedeng makita yan sa POP and COC. And meron tayong 21-day preparation with a 7-day hormone-free days that we can see in our combined oral contraceptive pills. Okay? Now, for our combined oral contraceptives, like what I've said, this is the combination of estradiol and the progestin. Okay? The estrogen component in our combined oral contraceptive is important. The dose is important, no? Because number one, the bleeding problems that you look, or the bleeding irregularities like your withdrawal or your intermenstrual bleed, okay? Yun yung isang concern kasi ng mga patients. So the estrogen dose can help with that, okay? Now, like what I've said, what are the non-contraceptive benefits? You take a look at that and look also in the combination. Okay, so as you can see, this is a screen captured from your Williams, no, the different combinations and the paired progestin. Okay, now when we look at the paired progestin, marami siya. Okay, structure, the time it was introduced into the market, and according to the interactions to the steroid receptors. Okay, so these are the progestin and the example, no, the natural progesterone, dydrogesterone, which we usually use in other, not just in contraception. No, we make use this in the bleeding problems or in pregnancy, no, and the others. Okay, as you can see. Now, depending on the classification or structural, kung saan sila galing, no, carbon-21, carbon-19, or spironolactone. Yung carbon-19, divided pa yan into estrine or gonanes. Your levonorgestrel, your desogestrel are from gonanes. Your drospirenone are from your spironolactone. Your cyproterone acetate coming from your pregnanes yan, coming from your carbon-21 progestin. So, madami siya. Okay? Now, for this, siguro pwedeng remember type of question lang to, no? So, yun. Now, for your marketing time, no? Depende. First gen ba yan? Second gen ba yan? Third gen ba yan? Or fourth generations, no? So, your third generations, andyan yung desogestrel and your etonogestrel. Okay? Your fourth generation, you have your drospirenone. Okay? Now, with regards to progesterone and its metabolic activity, it depends on what receptor it has an effect on, like whether it's a progestin receptor, your androgen receptor, glucocorticoid receptor, or your mineralocorticoid receptor. Okay, so this table will tell you kung saan ang mga receptors whether it's progestogenic, antigonadotrophic, antiestrogenic, androgenic, anti-androgenic, glucocorticoid, or anti-mineralocorticoid, no? That's why when you look at the side effects, look at the receptors. Tingnan nyo, no? Yung anti-mineralocorticoid is related to water retention, yung mga ganyan. Okay, or anti-androgenic or androgenic, pagka masyadong androgenic tong pills na to, you expect acne, okay? Because you know, sebum production depends on your androgens. Okay? Also, pwede rin nyo siyang tingnan on the non-contraceptive benefits like what I've mentioned kanina. Diba? Treatment of dysmenorrhea, hirsutism, menorrhagia, menstrual cycle regularity, bone mineral density improvement in older women. Lahat yan kailangan yung i-weigh the benefits versus the risk. Okay? And look into this as well. Okay? You also have to advise, of course, your patients when it comes to hormonal effects, no, headache, nausea, vomiting, which you can actually see, okay, sa lahat ng mga oral contraceptive pills natin or hormonal contraceptives natin, no. Now, with regards to bleeding patterns seen in OCP use, withdrawal bleeding refers to bleeding of OC users during the hormone-free interval. Okay, meaning for our combined oral contraceptives na 21-day preparation, yung sa 7 days na yon, na pill-free, doon siya mag-withdrawal bleed. Or breakthrough bleeding, which refers to unscheduled bleeding occurring during days with active pill use. Okay? So, I hope we are still good. Sige, let's talk about this. Question number 7. 23-year-old EE plus LNG, concerned because she missed her pill for 3 days on her second row. What is the best response? Okay, so this type of question, pwedeng analysis type of question to. Or create, kasi response ang tinatanong. A, disregard the current pack and start a new pack of 28 pills. B, take 1 pill as usual and continue with the remaining pill. C, she might need to take 2 pills and continue as usual. Or D, take the pill and continue as usual, but she needs to do backup method for the next 7 days. Okay, so higher order thinking skills kasi binigay niya sa inyo yung combination. Okay, and then also sinabi niya second draw and 3 days na raw niyang na-miss yung pill niya. So let us take a look at the answers. So mostly answer D, but may nakikita akong C and A. Okay, so let's talk about management of missed pill. Okay, specifically for combined oral contraceptives. So if a woman misses 1 or 2 active COC pill in any day on the first 3 weeks or starts a pack a day late, she must take the missed pill as soon as she remembers, take the scheduled pill at the usual time, and continue taking 1 pill at a time until pack is finished. No backup is necessary. Again, 1 or 2 on the first 3 rows. No backup is necessary. Now, if a woman misses 3 or more active COC pills in the first 2 weeks, rows 1 or 2, or starts a pack 2 or more days late, take the last missed pill as soon as she remembers. Take the pill scheduled for the day at the regular time. So, minsan dalawa yung naiinom nila. For example, 9 p.m. siya umiinom. Nakalimutan niya, kinabukasan ng umaga na alala niya. Inumin mo na agad. And then, 9 p.m. ulit. Okay? Kaya minsan dalawa yung naiinom nila. And, abstain from sex or use backup method for the next 7 days and continue taking the pill until pack is finished. Okay? So, yung sagot dun sa is actually letter D. Pero kulang ako dun. Kasi ang nakalagay dun is 3 or more on the 3rd week or the row 3. Take the last missed pill, continue taking the remaining pill, and discard the inactive pills. Immediately start a new pack and continue taking the pill until the pack is finished. Pag 3 or more, merong word na discard, inactive pills. On the 3rd week ha, kailangan i-discard mo siya and kumuha ka na ng bagong pack. Okay? And backup method again for the next 7 days. And when you say backup, condom or abstinence. Okay? So napakahirap, diba? That's why it's very important that you teach your patient compliance when she wishes to make use of combined oral contraceptive pills. Now, if a woman misses any non-hormonal pills or nasa last row siya, this is combined oral ha. Siyempre sa POP, all active hormones yon. Okay? Discard the missed non-hormonal pills and start a new pack as usual and keep taking COCs 1 each day. Okay? So that's how you manage missed pill. Okay? So question number 8, what is the medical eligibility criteria of perimenopausal patient with uncontrolled hypertension, smoking 15 packs per day, and desirous of combined oral contraceptive pills? So when you look at the stem of the question, okay, ano na siya, multiple factors wanting to have an estrogen-containing pills. Okay, what's the question? What's the answer? Okay, C, D. Okay, sige. Let's take a look at medical comorbidities. Okay, with combined oral contraceptives. So I do hope all of you has downloaded this already. No, we have WHO, MECTOL, Android, and iOS. Okay? So here, ang advantage nito is you can just tick kung ano yung meron sa patient nyo, the condition of the patient, and it will categorize whether it's category 1, meaning safe to use, category 2, okay, meaning you have the benefits of giving the oral contraceptive outweighs the risk, okay, or any form of contraceptive outweighs the risk. Pag category 3 naman, yung harm is greater than the benefits of the combined or the hormonal or the contraceptive. And category 4, absolute contraindication. Okay, so with smoking, remember yung question, more than 15 sticks per day. Okay, or 15 sticks per day. Kasi meron, ano yan, sa WHO, kung ilang sticks per day siya. Okay, so sabi, she likes to have COC. So, category 4 na yan, together with the age and the number of sticks na iniinom niya. Tapos, uncontrolled hypertension pa. So, the answer there is category 4. Okay? According to ACOG Practice Bulletin in 2019, no, for patients with hypertension, POC and LNGIUS are the appropriate options in women with hypertension. The use of COC in these women should be weighed against the risk of adverse pregnancy outcomes associated with hypertension, like yung increased risk of MI and stroke in women, and well-controlled and monitored hypertension who are less than 35 years old, pwede naman siyang mag-trial combination. If wala ka na talagang maibigay, yun lang yung available at that time. Okay, provided that the woman is healthy, she has no signs of end organ vascular disease, and does not smoke. Okay, pwede, trial. Okay, kasi wala ka na talagang maibigay. But ideally, POC or LNGIUS or copper IUD, pwede. Okay? Now, this is from WHO, no, na medical eligibility criteria, categorizing your different methods for patients with hypertension. Pag history lang of high blood pressure during pregnancy, no, pwede ka pa rin namang mag-COC, pero category 2 siya. Okay, best pa rin would be progestin-only contraceptives and your IUD or IUS. For patients with deep venous thrombosis or pulmonary embolism, COCs together with your combined patch or monthly injectables, category 4, basta any estrogen containing. Okay? Ang best pa rin for them, ang kaisa-isang natitira ay copper IUD. Okay? Pag history of DVT or acute DVT or major surgery na may prolonged immobilization, no? Those are the most, copper IUD is the most effective for those type of patients. Now, according to WHO, they recommend the use of low-dose COC containing less than 35 microgram combined with a progestin for patients with cardiovascular risk factors. No? Current evidence suggests that COCs containing LNG or norepinephrine and norgestimate are associated with the lowest risk, but the absolute differences, however, are very small. Okay? Now, for patients with dyslipidemia or mataas ang cholesterol, no? We know that estrogen has effects in lipid profiles. Okay? It enhances the removal of your LDL, which is a bad cholesterol, and it increases the level of HDL. Okay? That's why nga, diba, as much as possible, we conserve the ovary because of the estrogen effect to the heart and to the bone. Okay? And then moderate increase in triglyceride levels or does not increase the risk of atherogenesis. Okay, so ang importante actually for patients with dyslipidemia is the progestin component of that combined oral contraceptive pills. Okay, because the progestin component antagonizes these estrogen-induced lipid changes. Therefore, the choice and dose of progestin in COC may affect the overall change in the lipid level. Formulas with less androgenic progestin increase HDL levels more and triglyceride levels less than formulas with more androgenic progestins. Okay, if you're going to look at the table kanina that I showed you, diba, with different receptors. Okay, WHO again for dyslipidemia can use combination oral contraceptives with 35 microgram or less. Fasting serum lipid levels should be monitored often after combination oral contraceptives are initiated. Alternative contraceptives should be considered for women with uncontrolled LDL levels greater than 160 milligrams per DL. Okay, now let's talk about diabetes. Okay, use of combination does not increase in a woman's risk of developing type 2 diabetes. Now, if merong associated end organ, dun lang tayo magiging cautious. Okay? Category 4 kapag ka merong end organ. Okay? So, as you can see here, for endocrine disorders, mostly, lalo na kapag ka history lang naman of gestational diabetes, category 1. Okay? Pagka non-vascular diabetes, IUD pa rin ang pinakamaganda. Okay? Pag may end organ na, category 4. Okay, pag thyroid disorder, mostly are category 1, whether hyper or hypothyroid. Now, for obesity, when you say obesity, it is more than 30 kilograms per, or marked obesity, no? So, obesity and the use of COCs are independent risk factors for venous thromboembolism. Okay, meaning both COC and obesity merong risk for venous thromboembolism. Okay, so consideration is to give progestin only and IUD when counseling obese women about their options. Okay, now also women who are obese has an elevated risk of dysfunctional uterine bleeding. That's why LNG-IUS may be a beneficial choice in this type of women. Okay, this one is just categorizing. I'm sorry, I know maliit siya, but you can take a look at this sa ating WHO FP handbook. Now, for more than 35 years old, you're talking about perimenopausal already, the reduced risk of endometrial and ovarian cancers, beneficial effect on bone mineral density. For age alone lang to ha, kasi kapag may iba ng factors, of course, or multiple factors already, then you should be cautious in giving your combined estrogen-containing contraceptive methods. Okay? Now, can hormonal replacement therapy be used alongside or in place of contraception? women using sequential HRT should be advised not to rely on this for contraception. Okay, you can give women, especially kapag may heavy menstrual bleeding, LNG, IUS with estrogen for up to 5 years for endometrial protection as part of HRT regimen. And all progestogen-only methods of contraception are safe to use as contraception alongside sequential HRT. Alongside, meaning not for HRT purposes ang contraceptive effect ng ating mga hormonal contraceptives. Okay? Sige. Question number 9, a 44-year-old IUD acceptor for 9 years wants it to be removed and is concerned that she still might get pregnant. What is the next best step? Assurance? Remove IUD, request for FSH? Remove IUD, request for TBS? Or do not remove IUD and request for FSH? So the answer there is actually do not remove IUD because she is concerned that she might still get pregnant. But you can request for FSH. And what level of FSH that would tell you na she is already menopause or perimenopausal, more than 30 international unit per liter pag menopause na siya. Okay? So, you can request, no? Syempre, pag more than 50 naman na, yung percent is mababa na for pregnancy. Okay, especially if there are already hot flashes or bleeding irregularities secondary to a decreasing ovarian function. Okay, next. A 24-year-old newly gravid claims that her last menses was 4 weeks ago. She is concerned that she might get pregnant, and according to her, she had her sexual contact 2 days prior to consult. What is the next best step? Sige. So alam niyo na ang stem ng question na to is talking about emergency contraception. Okay, may sagot na letter D. Okay, may sagot na letter B. Iba-iba yung sagot, no? Actually, for this, ang sagot is letter C. Okay, and letter D pwede. But if we're going to look at the applicability in our country, wala tayong letter D. So, ang best sagot pa rin dyan is letter C. Okay? Pero pag sinabi, what are the methods that you can use instead of next best step? A, B, C, D, and then E, C, and D. Pwede yung letter E. Kasi pwede tong C, pwede tong D. But the stem says next best step. And applicability-wise, it's letter C. Kasi wala tayong locally available in our country. Definitely not letter B kasi hindi CPA ang dapat na combination. Okay, so what's the definition of emergency contraception? Preventing morning after, no? It prevents delaying of the release of eggs, pero may golden period yan. It has to be within 5 days or within 120 hours. Okay, kasi beyond that, hindi na po siya effective because the mechanism of action of which is that it inhibits the follicular development after the selection of the dominant follicle and before the rise in the LH. So meaning, pagka na-release na yung egg, wala na. Okay? It causes either a delay or arrest in the follicular rupture as well. Okay? There are many available methods. Pero what's locally available in our country is a combined progestin estrogen pills. Okay, merong ulipristal acetate which was marketed in our country before for myomas, decrease in myoma, pero ang alam ko phased out na siya, no? But it's being used at 30 milligrams of ulipristal acetate, 1 dose. Progestin only also LNG containing, no? One tablet na 1.5 or 2 tablets na 0.75. Okay, ang advantage nitong dalawa pero wala nga tayo is that yung mas madali siyang inumin, no, yung dosing kasi niya. Unlike in your combined oral contraceptive pills, no, making use of LNG and EE, maraming pills ang kailangan mong inumin. Okay, so these are the combination that we have. Okay? Again, LNG and Norgestrel lang ang pwede. So, hindi pwede ang CPA, hindi pwede ang drospirenone containing, bawal yon. Okay, kasi dapat LNG containing. Okay, in the Philippines, wala tayong dedicated. So that's why we make use of your combined EE and LNG 125 microgram or 150 microgram. Immediately after, you have to take it, 4 pills, and then the second dose again after 12 hours, 4 pills. Okay, they should be completed within 5 days, no? Again, immediately, preferably, yun ang ideal. Immediately, dapat, pagka naalala niya, inom na siya 4 pills. Okay, and then another after 4 pills. Okay, remember these are 4 pills combined oral contraceptive. So, you expect na talagang magsusuka sila. So, to prevent this, you can provide them with 30 minutes prior to the first and 30 minutes prior again to the second dose ng anti-emetic. Okay? Kasi kapag naisuka nila within 2 hours, you have to give them the pills. And not just one, depending, kasi baka isipin nyo, nagsuka siya sa vomitus, isa lang. So, isa lang ang papalitan natin. No. You still need to give them 4 pills. Kasi you cannot assume na na-absorb niya lahat yon. Okay? So, pag nagsuka within 2 hours. Pero kapag after 2 hours naman nagsuka siya, pwede nang hindi. Now, for patients who really cannot tolerate the oral form, you can give it high sa vagina. 4 pills then. And then another 4 pills after 12 hours. Okay, the dosing is very important. The timing is very important. Okay, so when you have patients na gusto ng ECPs, no, please counsel them on the use of regular method. Transition to a regular method. Because the effectivity of your emergency contraceptive pills is only for 24 hours. Okay, so meaning, nag-sexual contact ng Monday, okay, and then uminom ng pills na tapos ng Tuesday, nag-sexual contact uli ng Wednesday, she has to take again, okay, pills for that. Okay, kasi nga 24 hours lang. Okay, malapit na po. Okay, true, question number 11, true of the techniques in Pomeroy's for interval BPL. Sige, can you please answer? Okay, let us take a look at the answers. Letter E. We're talking about Pomeroy's here, ha? Sige. Definitely not letter E, no? Because the most distal part of the tube, this excise, is already out. Ang sagot dyan is actually A and B. Okay? The most distal part of the tube is your fimbria. Okay? Now, required ba tayo na kumuha ng spousal consent? No, well, according to the RA, to prevent spousal problems or for the sake of conjugal harmony, we can ask for consent from the husband. Okay, legal husband, of course. Okay? Verbal consent, basta nakalagay sa that the husband provided, kunyari nasa ibang bansa, no? Pwede naman, acceptable, basta signed by the client. Okay, it's very important, since you know that this is a permanent method, you have to provide them the 7 points of informed consent with regards to BPL, and these are the 7 points, no? And then also, counseling is very important because chance of regret is high, especially in the young patients or those patients who have few or no children, those who have lost a child, hindi pa married, having marital problems, or a partner who opposes permanent sterilization. So you have to really counsel them properly because mahirap ang mag-reverse. Okay? Now, with regards to timing, of course, pag postpartum, immediately or within 7 days. We call that postpartum BPL. Interval is 6 weeks after childbirth, or you can also do it within 7 days, or any time of the menses, or any time if it's if the patient is sure that she's not pregnant. Pag post-abortion, within 48 hours after an uncomplicated abortion. Now, let's talk about the technique. Okay? So, for technique, laparoscopy used for interval and post-abortal tubal occlusion procedures could be electrocoagulation or mechanical devices, no? But hindi naman natin to ginagawa just for for contraception. What we usually do is a mini laparotomy, 2 to 3 cm incision placed in relation to the uterine fundus, infraumbilically for postpartum, and suprapubically for interval procedures. You can do this for your pomeroys, your modified pomeroys, and your Parkland. That is for the abdominal incision. Now, for the excision of the tubes, now for pomeroys technique, a loop of the proximal portion of the tubal ampulla is elevated, which will reveal the vascular supply of the mesosalpinx. Okay, strand of absorbable suture to bilaterally ligate the tube and also will provide hemostasis. Okay, so the immediately distal to the knot to prevent the tube from retracting. Okay, so ganyan siya kapag pomeroys technique. Make a loop and then you cut. Okay? Now, for Parklands, of course, identify the avascular region, look at the window, and then rapidly absorbable. So, you have to put the knot, okay, and then ligate the portion of the knot. And then, pag Irving, okay, ano bang ano yan? Yan yung nililibing. Kaya Irving, okay, ini-embed. Okay, buried within the substance of the broad ligament. Now, for corner, fimbrectomy yan. Okay, yan yung most distal portion. Now, with regards to tubal excision for ovarian cancer prevention, fimbrectomy alone, hindi siya magpe-prevent ng ovarian cancer because it has to be salpingectomy, okay, or opportunistic salpingectomy, the removal of fallopian tubes for the primary prevention of epithelial fallopian tube cancers, peritoneal carcinoma in a patient undergoing pelvic surgery for another indication. That's what you call opportunistic salpingectomy. Okay, kapag ka may ibang indication, pelvic surgery. Okay, it's the stick that you prevent actually. Okay, or the serous tubal intraepithelial carcinoma. Again, salpingectomy, not just fimbrectomy. Okay? So, according to our POGS guideline in 2021 practice bulletin, with regards to opportunistic bilateral salpingectomy to reduce epithelial, ovarian, fallopian tube, and peritoneal cancer risk, according to them, at present, there is no direct evidence to show that doing bilateral salpingectomy for sterilization compared to tubal ligation resulted in a decrease in ovarian cancer. Okay? Malapit na po. So, what degree of temperature rise in Fahrenheit is needed for symptothermal method? 0.2, 0.4, 1, and 1.5. What's your answer? Okay. The answer is mostly C. In Fahrenheit, Okay. So, we talk about fertility awareness-based methods. Maiksi lang to sa ating Williams. It only talks about the standard-based method, the 2-day method, and the symptothermal method. Okay, for the symptothermal method, changes in the cervical mucus, which is the onset of fertile period, combined with changes in the basal body temperature, which is the end of the fertile period. So, a sustained 0.4 Fahrenheit rise in basal body temperature usually precedes ovulation. So you should abstain from intercourse from first day of menses through the third day after temperature increase. Okay? So this is very difficult. Mahirap to because you have to advise your patient na bago bumangon, okay? Because movement can increase the temperature. Okay, now standard-based method, avoid unprotected intercourse days 8 through 19. Okay, and the patient should be at 26 to 32 days interval. So you have to have compliant, highly motivated couple and a woman who is regularly menstruating for this fertility awareness-based method. Okay, the 2-day method naman relies on the awareness of vaginal wetness. So it's safe if a woman did not note mucus on the day of the planned intercourse or the day prior. Okay, but again, a lot of factors such as infection or medical comorbidities like diabetes can influence the mucus or changes in the vaginal mucus. Okay, so I think that would be all. Okay, these are my references. Remember, okay, number one or the first step in all the methods of family planning is counseling. It's very important that you counsel your patients. Okay, make them choose the appropriate method, okay, and help them decide what appropriate method or what is best suited method for her. And one factor is compliance. Okay, kasi yun ang pinakamagandang ibigay sa isang pasyente if she is compliant. Okay? So that would be all, Sir Ross. Thank you so much for listening.
Thank you very much, Doctora. We will have our part 2 of your second lecture for today. But before that, we're going to have a product presentation from BSV po. See you, Doctora. So now here's our product presentation from BSV.
Hello. Good day, doctors. Hello?
Yes, ma'am, we can hear you.
Okay. I'm Joser Kipones, product specialist from BSB Philippines. Thank you for the opportunity to share with you the solutions that support maternal and fetal health, backed by science, formulated by safety, and designed with patient compliance in mind. Today, we're here to present some of the key products that can help address common yet critical challenges in women's health. A study shows that 4 out of 10 pregnant women suffer from iron deficiency anemia or IDA. It's time to iron up with Hemap FA. Unlike conventional iron supplements, Hemap contains carbonyl iron, a pure high percentage elemental iron with high bioavailability, low toxicity, and minimal GI irritation. Enriched with folic acid and zinc, Hemap FA helps boost immunity support, hemoglobin production, and protect against oxidative damage during pregnancy. With its gentle formulation, negligible metallic taste, and once-daily dosing, Hemap FA ensures better compliance and comfort for expectant mothers. Hemap FA, iron absorption minus the irritation.
Good day, Doctor. I'm Kevin, also from BSB Philippines. Studies have shown that higher doses of DHA and EPA are associated with fewer serious maternal and neonatal adverse events. Start nurturing the first 270 days of life with Natalmin DHA, your partner in ensuring optimal fetal development. Formulated with high levels of DHA, Natalmin DHA supports development of the brain, eyes, and central nervous system, strengthening of the heart, immune system, and anti-inflammatory response. It is better compliance with its chocolatey taste that patients actually enjoy. Sustained adherence to treatment. Again, dear doctors, Natalmin DHA, high DHA for the developing baby, optimal care for mom and child. And for our brand of progesterone, 1 in 4 women suffer from abnormal uterine bleeding. MyProgen is your trusted partner in managing abnormal uterine bleeding and heavy menstrual bleeding. Formulated with natural, micronized progesterone, MyProgen offers a safer alternative to synthetic preparations while delivering multiple benefits. It regulates the menstrual cycle, it reduces bleeding, volume, and duration. And it also stabilizes endometrial fragility, inhibits endometrial overgrowth, and ensures better absorption and bioavailability. Cost efficient, well tolerated, and clinically reliable, MyProgen is the smart choice for hormone balance and cycle control. Again, dear doctors, MyProgen, the cost efficient micronized progesterone. Thank you, dear doctors, for your time and attention. We hope we have given you greater confidence with our products, HEMAP FA, Nitalmin DHA, and MyProgen, in supporting the health and well-being of your patients. Again, we are from BSP Philippines, your partner in bringing life to life. Thank you.
Pregnancy is a profound journey of transformation and joy in a woman's life. A time to celebrate milestones and embrace the powerful changes unfolding within her. Protecting both lives begins with prioritizing health. Nourishing both mother and child is the foundation of vital development. Key nutrients help safeguard against serious concerns, like neural tube defects. Luckily, much of the NTD burden is preventable. Starting folic acid before conception and continuing through pregnancy is vital. But did you know there's a more superior form of folic acid? A readily utilized form of this crucial vitamin. Introducing Foladvance with 5-methyltetrahydrofolate, the active form of folate that the body can use immediately. Unlike regular folic acid, it does not require conversion in the body, making it ideal for supporting a woman's health even before pregnancy begins. Foladvance, your partner in nurturing life, optimal nutrition, and expert care. Because sometimes knowing you're giving more than enough is what gives you the courage to begin. Celebration of being a woman is easy if nothing is holding you back. Like pain, especially if that pain is oftentimes misunderstood. Symptomatic impact of endometriosis affects millions of women with delayed diagnosis, since most conditions do not have noticeable symptoms in the early stages. Help is on the way as we introduce Dianogest Evifact, an oral treatment formulated to help reduce hormone production linked to painful symptoms of endometriosis. There is now a treatment option for long-term management of life-hindering endometriosis-associated symptoms. Dianogest Evafact, ending endometriosis pain, one tablet daily. Every woman's journey is different, but every woman deserves support that's backed by science and rooted in care.
At BSB Bioscience Philippines, we are serious with our mission of bringing life to life. One of the therapy area of focus of BSB is women's health. So this explains a great deal of our understanding of womanhood and motherhood. We ensure our products like EvaPack or Dynagest and Fall Advance are not only scientifically backed, but accessible, high quality, and economical, especially for Filipino women.
From healing to hoping, there's 2 new reasons to celebrate brighter beginnings. Dianogest Evafact, your daily dose of endometriosis relief. And 5-methyltetrahypofolic acid, Fall Advance, ensuring a safe mommy and a healthy baby. Let your journey continue with care you can trust. Dianogest Evafact and 5-methyltetrahypofolic acid, Fall Advance. From BSV Bioscience Philippines Incorporated. Supporting women's important journeys, lighting the way forward.
Life is a journey where each stage of life comes with escalating curiosity and excitement, with increasing stamina and vigor. As we age, we experience different health challenges that may lead to pain and anxiety, impacting our quality of life, so much so that it disrupts our daily activities altogether. It has been qualified that 1 in 10 women suffer from endometriosis, a significant health problem that may lead to infertility, which also causes severe physical and emotional pain. Men, on the other hand, are at risk of having prostate cancer, the 3rd most common cause of cancer death in the Philippines. BSV Bioscience Philippines is your partner in helping your patients relieve the pain of endometriosis and manage your patients with prostate cancer with our leuprorelin acetate, Luprodex. Luprodex, BSV's brand of leuprorelin acetate, is a GnRH agonist that is proven to decrease pelvic pain and ease endometriosis in women. Luprodex is also used in the management of prostate cancer. Luprodex is a slow-release injection that works to treat prostate cancer by reducing levels of testosterone to slow down the growth and spread of the cancer. BSV's Leuprorelin Luprodex employs a microsphere-based delivery system and is available in 3.75 milligrams and 11.25 milligrams depot formulations, which releases the drug in a graded fashion. Luprodex 3.75 milligrams degrades over a period of 1 month, while Luprodex 11.25 milligrams degrades over a period of 3 months. Luprodex is backed up by BSV's more than 50 years of pharmaceutical experience. It is produced and manufactured in our state-of-the-art facilities in Germany to ensure safety, efficacy, and quality. Leuprorelin acetate, Luprodex, promotes better efficacy due to consistent plasma levels. Drug stability inside depot formulation, and improves patient compliance. Leuprorelin acetate, Luprodex 3.75 and 11.25 milligrams are now available. Ask your BSV representatives for more details.
pregnancy is unique. And although every expecting mother's aspiration is to have a healthy and stress-free pregnancy, complications often occur that sometimes lead to a stressful process. Based on World Health Organization, there is an estimated 13.4 million babies born preterm in 2020, and preterm birth complications are the leading cause of death among children under 5 years of age. It is our role to support our patients have a healthy and smooth pregnancy. That is why it is important for us to have a reliable, safe, and natural product to help our patients through their journey. Giving oral progestin will help normalize the progesterone level in the body to assure an on-time delivery in pregnant patients and improve menstrual cycles of non-pregnant women. Progesterone is our natural solution to help women reduce the risk of pregnancy complications such as threatened abortion and preterm labor. Progesterone is natural, making it safe not only for pregnant women, but also for women trying to conceive by preparing the uterus for pregnancy. Progesterone, when micronized, provides easier absorption, thus promoting higher efficacy. BSV Bioscience is committed in bringing light to life by providing our partners a solution to our patients' needs. Started in 1971, BSV is backed up by 52 years of experience in the pharmaceutical industry. Each produce is meticulously checked and reviewed to ensure that our offering is of great quality, giving you a wide range of products for women's health and fertility since 2018. It is our pleasure to introduce to you the newest product of BSV, micronized progesterone Myprogen. Progesterone Myprogen is natural, making it safe for your patients, micronized for improved absorption and efficacy, economical, promoting more patient compliance. Micronized progesterone Myprogen, now available from BSV Bioscience Philippines.
Thank you very much, BSV. And now for the second lecture. Once again, here is our speaker, Dr. Marimitz Isidro Borlaza.
Thank you, Sir Russell. I'll just share my screen. Okay, so I hope may energy pa ang ating mga residents. So my task for today is for this time is on cesarean section, trial of labor after cesarean delivery, and placenta and fetal spectrum. Okay, so my intended learning objectives are to be able to discuss the following topics: your cesarean delivery and DOLAC, as to anatomical correlations, clinical indications, patient preparation and procedures. Also, I will be discussing placenta acquita syndrome and uterine rupture as to its clinical signs and symptoms, diagnosis, and management. Okay, so let us first talk about cesarean delivery. Okay, so we will take cesarean delivery on its basic concepts like anatomy, the types of abdominal incision, the types of uterine incision, patient preparation, and post-operative care. Okay? Remember again that counseling in general, when you manage a patient, is very important. So counseling during antenatal care, we should be able to offer all pregnant women information and support to enable them to make informed decisions about childbirth. Okay, and we have to be able to discuss mode of birth with all pregnant women, no, because we cannot assure them of 100% normal spontaneous vaginal delivery. So you have to be able to also counsel them on the risks of both vaginal as well as cesarean section, and also discuss the benefits, the risks, including long-term effects. Okay? Now, according to our POG CPG in 2021, CS delivery increases the risk of maternal morbidity and mortality. Okay, in patients with previous CS birth, TOLAC does not increase the risk versus planned elective repeat cesarean section. So TOLAC can be offered after discussion of the factors that may influence success and failure. If with previous CS delivery or CS more than or equal to 3 times, it may increase the risk of morbidity and mortality. And prostaglandin use for cervical priming may increase the risk of uterine rupture with prior CS. That's why it's not recommended. And labor induction and augmentation is not recommended in patients with prior CS delivery. Okay, now let's take a look at the different definitions. Okay, when we talk about CS delivery. Okay, so CS delivery is a birth of a fetus via incisions in the abdomen or the laparotomy, and then the uterine wall or the hysterotomy. Okay, this is not applied to the removal of the fetus from the abdominal cavity in cases of uterine rupture or with abdominal pregnancy. So we don't call an ectopic pregnancy abdominally located as cesarean section. Okay, now we say peripartum hysterectomy when we say CS hysterectomy performed at the time of CS delivery, or a postpartum hysterectomy within short hour after vaginal delivery may be secondary to a profuse vaginal bleeding or postpartum hemorrhage necessitating hysterectomy. Okay, now we call it perimortem CS delivery in a woman who is about to die, and a post-mortem CS delivery in a woman who recently died. Now, what are the different indications for cesarean delivery? It's always maternal and fetal indications to do cesarean delivery, not unless there is malpresentation or, for example, prior neonatal birth trauma, okay, or congenital anomalies or macrosomic patients, no. But in our country, the most common reasons for cesarean delivery is cephalopelvic disproportion or not prior cesarean delivery, a non-reassuring fetal status, and malpresentation. Okay? Okay, sige. Question number 1. The following structures is/are is involved in incision of the abdomen during CS. Okay. A. Internal and external oblique aponeurosis. B. Ilioinguinal nerve. C. Superficial epigastric artery. D. A and B. And E. All of the choices are correct. Okay, so this one is an analysis type of question because they want you to think on the type of incision, paano ba yung transverse incision, and the anatomical correlations. Okay, let's take a look at the answers. Letter C, A, E, iba-iba yung sagot. Sige, let's take a look at the anatomy of the abdominal wall. Okay? So for the anatomical correlation, of course, we have to know our anatomy. Okay, even with other procedures, gynecologic or obstetric procedures, anatomy is the basic concept that we need to understand. Okay, and when we take a look at the skin, we need to look at the longer lines. Okay, because it will describe the orientation of the dermal fibers, and it is naturally arranged as in transverse arrangement. Okay, so it transversely arranged so that when you do vertical skin incisions, as you can see in this picture, okay, it causes more lateral tension, thus wider scars, as compared to your pan and steel or your low transverse incision, wherein it follows the longer lines. Thus, low transverse incision or pan and steel, the only advantage that you can get from that is a superior cosmetic result. Yun lang. Okay? But we know so well that inside, or meaning other layers, hindi siya ganon. Okay? And the reason why is because of the longer lines. Okay? Now here, in obstetric, the midline vertical or suprapubic transverse incision is chosen for laparotomy. Okay, as you can see, you will be traversing these layers. Your landmark will be your symphysis pubis and your umbilicus, no? Especially when you do vertical incisions. You have here your internal oblique, your rectus abdominis, your subcutaneous tissue, which is divided into scarpas and Camper's fascia, and then your labia majora from inside going up. Okay? The labia majora is also important because we know that there's a continuation superiorly into the abdomen, so that when there is a hematoma on the labia majora, it can also affect the pelvic abdominal cavity. Okay, so this one, the picture to your right, will just tell you about the arcuate line, what is above the arcuate line, and what is below the arcuate line, and also the importance of the aponeurosis of the different muscles, like your external oblique, your internal oblique, and your transversus muscle, and also the location of your inferior epigastric vessels and your inferior epigastric artery as well. Okay, so another picture taken from the limbs. As you can see, you have here the external oblique, the internal oblique, and the rectus, as well as the pyramidalis. Take note of your inguinal hernia because cesarean sections, especially transverse, are prone for hernias. And then also your superficial inguinal ring. Okay, at this point, again, on your transverse incision, no, take note of that. And then also, abdominal wall, muscles, and rectus sheath in this right side of the picture, you'll be able to appreciate more. Okay, you have here the transversalis fascia. Okay, here is the imaginary arcuate line, as you can see. And then here is the round ligament, which is actually connected also to your labia majora. Okay, now, besides the layers of the abdominal wall layers, you also have to know the different blood supplies. Okay, so between the internal oblique and the transversus abdominis, there lies your neurovascular plane, which actually corresponds to a similar plane in the intercostal space. No? This plane contains the nerves and arteries that will supply your anterolateral abdominal wall. Okay, in the anterior part of the abdominal wall, these nerves and vessels will exit the neurovascular plane and will lie mostly in the subcutaneous tissue. So as you can see here, the superficial epigastric vessel is surgically important when doing low transverse incision. So here you can see the superficial epigastric artery. Okay, and the inferior or deep epigastric vessels, which is surgically important when doing Maillard's incision. Okay, remember that low transverse fascial incision, which is oftenly used in gynecologic surgery, should not extend beyond the lateral margin of your rectus muscle to avoid the nerve and your inferior epigastric artery or vessel, as you can see here. Okay, in addition, the sutures that extend lateral to the edges of the incision should be avoided, as they may entrap the iliohypogastric or your ilioinguinal nerve, okay, which may lead to denervation injury or pain. Okay, so yun yung mga dapat nating iwasan. Okay, now again, with regards to the blood supply of the lower abdominal wall, as you can see here, the deeper musculofascial layer parallels to the subcutaneous vessel. Okay, as you can see, the inferior epigastric and the deep circumflex artery or vessels will branch from the external iliac and their course parallels to that of the superficial counterpart. Okay, the deep circumflex artery lies between the internal oblique and the external and the transverse abdominis muscles, as I have mentioned. Okay, and then the inferior epigastric artery will originate lateral to the rectus muscle. Okay, and will run diagonally towards the umbilicus, as you can see here. Okay, and intersect the muscle's lateral border. Okay, so it's very important that we take note of those structures that we can transect during opening up of the abdominal wall. Okay, next we have the nerve supply. Okay, the innervations of the abdominal wall arises from the abdominal extension of the intercostal nerves 7 through 11 and the subcostal nerves T12, the iliohypogastric and the ilioinguinal for both L1, and then dermatome T10 will lie at the umbilicus. Okay, so for our friendly anesthesiologists, our friends in anesthesia department, importante sa kanila yung dermatome 10 whenever they do induction of anesthesia for obstetric indications. Okay, so cutaneous sensory innervation of the abdominal wall is derived again from intercostal nerves and iliohypogastric and ilioinguinal nerves. Okay. So this one for iliohypogastric nerves, it will supply the skin of the suprapubic area, and your ilioinguinal nerve will supply the lower abdominal wall. Okay, and this ilioinguinal nerve will branch out into become your anterior labial nerve to supply the labia majora and the medial portion of the thigh. Okay. Now let's talk about the vertical incision or the uterine incision or the abdominal incision. Sorry. Okay. So question number 2, what is the advantage of phalansteal incision over vertical incision? Okay, so this is just a remember type, napakadali. So 1 ang score niyan. Okay, what are your answers? Let me see. So, A. Okay, sige. It follows the Langer's line, providing superior cosmetic result. Okay, so these are your abdominal incision. You have here your suprapubic transverse incision, phalansteal or maillard. You have here your vertical and your periumbilical midline vertical. Okay, your periumbilical midline vertical is being used mostly on your gynecologic as well as your maillards. So what we usually do is yung phalansteal and your vertical incision. Okay? So let's talk about technique muna. Okay, I don't know if they're going to ask this, no, but I'm going to discuss it anyway, no. So with the phalansteal incision, the skin and tissues are incised using a low transverse, slightly curvilinear incision. Okay, this is made at the pubic hairline, which is typically 3 cm above the superior border of the symphysis pubis. And then, the incision is extended laterally to accommodate delivery about 12 to 15 centimeter, is typical. Now, your maillard incision will differ mainly from phalansteal in that the rectus abdominis muscle, bellies, and their investing rectus sheath are transected horizontally to widen the operating space. Okay, so it is technically more difficult due to required muscle cutting and ligation of the inferior epigastric arteries, which lies laterally to these muscle bellies, as I have mentioned kanina. Okay, so after that, after the 12 to 15 cm laterally, going back to the technique, you have to do sharp dissection to the subcutaneous layer. You have to be able to identify the superficial epigastric vessel in that area, and then also dissect the aponeurosis of the internal and external oblique and transverse abdominis muscle, and also be careful with the inferior epigastric vessel, which is at the lateral border of the rectus abdominis muscle, and then do your dissection of the superficial fascial by separating it cephalad, and then bluntly dissect the transversalis fascia and then into the peritoneum eventually. Okay? Now, what's the technique of vertical naman? Okay, you have to make an incision 2 to 3 cm above the superior margin of the symphysis pubis, then about 12 to 15 cm long vertically. Okay, and then sharp dissection through the subcutaneous tissue as what you have done with your fan and steel. And then a small opening can be made sharply at the upper half of the lineal alba, and then midline separation of the rectus muscle and the pyramidalis muscle. So as you can see, as you have noted, there are more structures involved in your fan and steel as compared to your vertical. That is why, again, superior cosmetic result lang ang advantage ng ating fan and steel over our vertical incision because of a lot of structures being dissected in your fan and steel, more adhesions, probably more bleeding. Okay, so on the second operation, mas mahirap siya. Okay, now with regards to obese patients, according to our POG CPG in 2021, obese is defined as a BMI of more than or equal to 30 kilograms per meter squared. The recommendation is a transverse skin incision for obese women who would undergo cesarean section. The quality of evidence is strong, and the strength of recommendation according to our CPG is also strong. Okay? Now, this one will just give you the differences of the transverse and vertical incision. As what I have said, the only advantage is cosmetic result. Okay? For pain, poorer, okay, sa vertical because of the tension. Okay? And then maraming neurovascular structures ang ating magsasagasaan with transverse incision. Okay? Sige. So, we're done with anatomy and with the types of abdominal incision. We now go to the uterine incision. Okay? So, this one will give you the different incisions or hysterotomy as to Kerr, which is an incision made in the lower uterine segment transversely, or chronic, wherein you do a low segment vertical incision that can extend upward. Okay, the operation of choice that we usually do is a Kerr's incision because it's easier to repair, located at a site least likely to rupture during a subsequent pregnancy. Okay, we know that it's the fundal area because it's at the point of maximal uterine contraction or pressure during uterine contraction. Okay, so pag Kerr, malayo siya doon. So, hindi siya prone to rupture, but there's still a risk of rupture. And then, it also does not promote adherence of bowel or omentum to the incisional line. As opposed to your chronic, which causes more extensive dissection of the bladder and may extend downward to the cervix and involve the bladder, which also has a more likelihood to rupture. Okay, now for your classical incision, vertical incision in the body of the uterus above the lower uterine segment and reaching the fundus. Okay, what would be the indications for your classical incision? If the LUS cannot be exposed or entered safely because of bladder adherent, myoma in the lower uterine segment or your tumor previous, invasive CA of the cervix, a large fetus in transverse lie or in a dorso, anterior, or back down. Okay? Placenta previa with anterior implantation, very small fetuses in breech with the lower segment not thinned out, and a massive maternal obesity as what was the recommendation kanina with transverse incision sa abdomen. No? Dito sa ating obese patient where upper uterus is easily accessible, classical incision ng recommendation. Okay? Now, is exterioration of the uterus acceptable? Yes or no? Okay lang ba na ilabas natin? Will it not promote occurrence of infection or risk of infection? Okay, so exterioration according to POGS is acceptable. Okay, may recommend exterioration of the uterus during repair to decrease blood loss. However, if you're going to look at the quality of evidence and the strength of recommendation, hindi siya ganon kaganda. Okay? Now, with regards to closure of the layer, single layer versus double layer closure, ang recommendation is that double layer closure of the uterus after the primary or repeat CS for a thicker post-operative residual myometrial thickness is recommended. Okay? So, double layer ang gusto nila. Okay, the quality of evidence is low to moderate and the strength of recommendation is strong. Okay, now technique again, no? So abdominal closure, of course, you need to know you need to have a complete counting, both for the instruments, the sharps, and the sponges. Okay, for the rectus muscle, 1 or 2 figure of 8 sutures of 0, okay, or 1 suture. And then for the fascia, continuous non-locking technique with delayed absorbable suture. Okay, pero tayo usually interlocking, no? And then this one is from Williams. And then subcutaneous tissue not to be closed if less than 2 cm with thicker layers. However, closure is recommended to minimize seroma and hematoma formation. Okay, for thicker layers. For skin, running subcuticular stitch of 4O delayed suture. Syempre, with adhesive glue or staples, hindi naman natin yung ginagamit. Okay? So, according to our POGs, for peritoneum, may not do closure of peritoneum for prevention of post-op pain and adhesion. And then, closure of subcutaneous tissue is recommended to prevent wound complications. Okay? So, now for preparation, delivery, availability. Okay, recommend that facilities giving OB care should have the ability to initiate CS in a time frame that best incorporates maternal and fetal risks and benefits. Of course, we need informed consent, okay, with witness or witnesses, and the timing of scheduled cesarean delivery. Okay, to be able to assure a fetal maturity is our goal, okay, prior to the delivery. And according to the ACOG, they recommended delaying non-medically indicated deliveries until 39 weeks completed, okay, completed weeks of gestation or beyond. Now, if ERCD is planned, it is essential that the fetus should be matured. So for patients who are not sure of their menses, walk-in patients, walang ultrasound, no, you have to have an ultrasound to establish the maturity, making use of the femur length, okay, or the DFE for the maturity. Okay? Now, timing of scheduled delivery according to POGs, optimal time to plan an elective CS at term is at 39 weeks to 39, 6, and 7. Quality of evidence is very low. Strength of recommendation is weak. Okay, now for perioperative care, sedative at bedtime, the night before the surgery, no solid food 6 to 8 hours before the procedure, clear liquids up to 2 hours before surgery can still be given, ERAS protocol, clear carbohydrate drink up to 2 hours before surgery, and early post-operative feeding. Of course, you have to have an evaluation by OB and anesthesia team, and then baseline CBC. Antacid can be given before regional anesthesia. Left lateral tilt to aid venous return and avoid hypotension. Fetal heart sounds or baseline CTG can be done to document for prior to surgery. Hair clipping, not shaving. And then electrosurgical grounding pad, of course, insertion of Foley catheter. And then specific management of comorbidities, if there is. Okay, for infection prevention, antibiotic prophylaxis, single IV dose of beta-lactam antibiotic, either cephalosporins or extended spectrum penicillin. 1 gram dose of cefazolin is an efficacious and cost-effective antibiotic. So it is recommended within 60 minutes prior to cesarean section. Now, you can give additional dose if the blood loss is more than 1,500 ml or a duration of longer than 3 hours. Okay, CDC, the recommendation is, according to CDC, they recommend 2 gram dose for more than or equal to 80 kilograms and 3-gram dose for more than or for 120 kilograms. Okay, prior to cesarean delivery. And then glycemic control for patients with diabetes or discontinued smoking prior to cesarean section, of course, even during pregnancy. And then intraoperative normothermia. Okay, and the surgical safety. Okay? Now, vaginal antisepsis is also recommended to reduce maternal infectious morbidity. And then changing gloves intraoperatively after placental delivery may be considered to reduce SSI. And removal of dressing between 24 to 48 hours after surgery. Okay? Sige, let's proceed with question number 4. While bringing down the bladder during cesarean section, a gush of clear fluid was noted. So what is the next best step? Refer to the urologist, remove IFC and reinsert, installation of fluid through Foley catheter and into the bladder, and repair of the bladder tear. So what's the answer? So some answered A, majority C. Sige. So bladder injury is typically the most common, okay, complication of cesarean section, and it's usually identified, hopefully intraoperatively. Okay, and ang isang sign yan is a clear gush of fluid. Okay, that you'll be able to know that it's a bladder injury. Okay, so in suspected cases, cystotomy can be confirmed with retrograde installation of fluid through a Foley catheter and into the bladder. So yun yung sagot. Okay, a dilute sterile water can be given. Okay, can be an option. Pero kung merong methylene blue, pwede rin naman. Okay, leakage of the indicator fluid will aid in laceration identification and delineation of its border. Okay, the dome is lacerated most often. Okay, and trigone injuries make up the remainder. Okay, so the most commonly affected structure of the bladder is the dome for your cesarean section. So the next best step is a retrograde installation of fluid through a Foley catheter into the bladder, and then of course repair of the bladder or referral to a urologist depending on the extent. Okay, there could also be ureteral injury. Okay, so you can give IV dye administered to inspect for extravasation, either a methylene blue, okay, or a 25 or 50 milligram 10% sodium fluorescein, which will stain bright yellow, and bowel injury. So all of these injuries needs referral also, no, to other department or specialties. Okay, almost done with cesarean section. Let's talk about the post of care after cesarean section. Again, oral feeding within 2 hours after cesarean delivery is recommended. You can give or provide pneumatic compression stockings for patients who underwent cesarean delivery, especially for high-risk patients, no? And then heparin should not be routinely used as a venous thromboembolism prophylaxis in patients after cesarean delivery. Early mobilization after CS is part of the Enhanced Recovery or ERAS protocol. The urinary catheter should be removed immediately after cesarean delivery if placed during surgery, okay, to prevent infection. Abdominal binders may be used to decrease cause of pain and patient's anxiety with regards to opening up of the wound, and increase mobility, which we need, no, early mobilization for faster recovery. And then removal of the surgical dressing 24 hours post-cesarean delivery or 24 to 48 hours. No particular wound dressing is recommended following cesarean section. And it is recommended that all women have their follow-up within the first 3 weeks post-CS. Okay, the initial visit should be followed up with the ongoing care as deemed necessary and concluded with a comprehensive postpartum visit no later than 12 weeks after. Okay, so that is for our cesarean delivery. Okay, Sige, now let's go into our second learning objectives, which is to discuss placenta acquita syndrome or PAS and TOLAC also and uterine rupture. Okay? So for the TOLAC, so hindi na ngayon uso yung once a C-section, always a C-section. Okay? It's not, it doesn't hold true anymore. Okay, so this one are just acronyms. You can just go through that, no, for our cesarean or TOLAC. Okay? Sige, so question number 5. Agravida 3, para 2, 2002, previous LSCS once for placenta previa on her 32nd week age of gestation, desirous of VBAC. What is the most pertinent history needed to be asked for this patient? Okay, let's take a look at the answers. Okay, sige. For this, all are important actually, but most pertinent, who wants a VBAC or desirous of VBAC, would be operative technique for her cesarean section. Okay, because there are factors that will influence a successful trial of labor in a woman with prior cesarean delivery. And an unknown incision will increase the failure rate and is high risk also for uterine rupture. Okay? For low risk and those who will favor success are patients who have transverse incision or those with CS and then with vaginal delivery or vice versa. Those, of course, with appropriate counseling and sufficient personnel and equipment. Favoring success will be those who have 1 or 2 prior low transverse incision, no recurrent indication or current preterm pregnancy. Now, increase in failure rate will include the following. Okay, as you can see, unknown incision, low vertical incision, or those who will go through labor induction, or those with multiple prior cesarean deliveries, those with short interdelivery interval. Okay, and those who have higher risk for uterine rupture will include, of course, classical or the incision, with those with prior uterine rupture, those with transfundal surgery, okay, and those patients who refuse to have a VBAC. Okay, now the types of prior uterine incision correlates with the risk of rupture. Okay, so for one low transverse incision, it's 0.2 to 0.9. If multiple low, it will double up. Okay, if low vertical, it's 1 to 7. If it's classical, it's 2.2 to 9% yan, not 2.9, 2 to 9%. Or if prior uterine rupture, of course, kapag ka-upper, mas mataas compared sa lower. Okay, so di naman siguro sila magtatanong ng percentage, I hope, no, but these are the prior incision with estimated risk of rupture. Okay, sige. Next, question number 6. 18-year-old with 1 previous low transverse CS is now 38 weeks and wants a vaginal birth. Which of the following is an absolute contraindication to TOLAC? Medyo masasagot nyo na to with the slides I gave kanina. Again, absolute contraindication. Napakadali naman itong tanong na to, Doktora. Okay, sige. Of course, the answer is letter B. Okay, so the following, according to our POG cesarean section, are contraindications. Previous classical or inverted T, or those with transfundal. Uncertainty of the type of previous CS scar because there's no available previous OR record. So you should be able to request early in pregnancy. Previous multiple low transverse segment uterine incision or scar, 2 or more previous CS. Previous hysterectomy or myomectomy. Okay, previous myomectomy is associated with 0.5 to 7% risk of uterine rupture in subsequent pregnancies. Of course, previous uterine rupture, presence of contraindication to labor such as previa, acquita, or malpresentation, and then no informed consent, Okay, so those are the absolute contraindications for your cesarean section or TOLAC after cesarean section. Okay, number 7, which of the following is the most important aspect when counseling a patient for TOLAC? Availability of products, availability of anesthesia, continuous and immediate surgical capability. Again, all of these are important, but it's the immediate surgical capability. Okay, so if you're going to plan for TOLAC in your patients, nakita nyo sa clinic, make sure that you advise them to go sa hospital where you are affiliated that has the capability to do emergency cesarean section. Okay, so when you plan cesarean TOLAC after a CS, counseling and informed consent is number 1. Okay, you should be able to counsel your patient on the risks and the benefits and the long-term complications. So we know that an informed consent is very important to protect you, okay, and protect the patient as well in the hospital. So it has to be an educated and shared decision making about the risks, the benefits, or alternatives, okay, that you can give. It should be voluntary, syempre. And these are the elements of an informed consent. I don't know if you have in your institutions, kung meron kayong sarili kanya-kanyang consent na prepared already or template. Mas maganda kung may Tagalized version or Tagalog version, especially for your patients na hindi yung kanilang education. So that dapat lahat nandun, like the nature, the risks and benefits, reasonable alternatives, the risks and benefits of the alternatives that you offered, okay, and the capability of the patients understanding the elements 1 to 4. Importante din yon. And when you counsel your patients with regards to the risk, okay, you have to tell them the different risks like uterine rupture, dehiscence, possibility of conversion to hysterectomy, possibility of risk of thromboembolism, okay, transfusion, uterine infection, or even death. For fetal risk, there could be antepartum stillbirth, intrapartum stillbirth, okay, or HIE or hypoxemic ischemic encephalopathy as well as neonatal death. Okay, so this table will just compare the maternal risks from TOLAC to ERCD. Okay, what is clinically significant, okay, when you look at the p-value less than 0.001 is that your uterine rupture, okay, your transfusion related, and your uterine infection, okay, which is higher in TOLAC as compared to your elective repeat cesarean delivery. Now, with regards to your TOLAC and your ERCD in fetal and neonatal risk, as you can see here, yung ERCD, hypoxemic ischemic encephalopathy, halos 0 siya. Okay, the rest hindi ganong kalayo. Okay? So, after counseling and informed consent prenatally, okay, you get the previous record of the type and indication of the cesarean section like what I have mentioned. Again, because it will affect the mode of delivery. Okay, there could be the doubling or tripling of rupture rate in women with 2 compared to 1 prior low transverse hysterotomy. Okay, and if the interval delivery is less than or equal to 18 months, it is associated with a 3-fold risk of rupture compared with more than 18 months. Okay, and fetal size also is inversely related to VBAC rates. And for fetal death, VBAC rate is 87%, uterine rupture is 2.4%. Now, with induction of labor, the uterine rupture rate will increase to 3.4%. Okay? Also, yung indication of prior cesarean delivery will have a factor. Okay? Pag breach, 90%. Breach VBAC rate is 90%. If fetal compromise, 80%. Labor arrest, 60%. And prior second stage arrest, is associated with second stage uterine rupture. Okay, yan yung mga prior CS indication and the success rate to VBAC. And then multiple gestation, the rupture rate is at 0.7 to 1.1%, and the VBAC rate is 75 to 85%. So mataas din siya. According to ECOG, twins with prior LTCS can also undergo TOLAC. Okay, now with regards to maternal obesity, like what I've said kanina, it's a factor also. It will depend on the BMI. Kapag normal BMI, the success rate is higher as compared to your BMI na more than or equal to 40, which is 61% lang ang kanyang success rate. Okay? Now, do we do imaging prior to incision to look at the thickness of the lower uterine segment? Okay, because they say that the thickness of the lower uterine segment was a strong predictor for uterine scar defect in women with prior cesarean delivery. Okay, however, they could not find an ideal threshold value to recommend TOLAC. Okay, according to Williams 26th edition. Again, I took the liberty in looking at a study, okay, on the predicting uterine rupture risks using lower uterine segment measurement during pregnancy with cesarean history. Okay, this is just a review. And the most recent systematic review and meta-analysis suggests that LUS of more than 3.65 millimeter should be safe for a VBAC. 2 to 3.65 millimeter is probably safe, and less than 2 millimeter identifies a patient at higher risk for uterine rupture or dehiscence. Okay, so after looking at the previous cesarean section, after the ultrasound, okay, of the thickness or the thinness, you can also request for a transabdominal ultrasound to rule out placenta acquita and check for the CS scar, like what I have mentioned. Okay, remember that patients with prior cesarean delivery has a risk of placenta acquita spectrum, no, because of the destruction of your Nittabooks layer, which we will talk about later. Okay, now when you request for transabdominal ultrasound and look at the CS scar, no, the uterine niche is a kind of cesarean scar defect, which is defined sonographically as a triangular anechoic filling defect with a depth of at least 1 millimeter in the anterior wall of the uterus, usually between the uterine body and the cervix, immediately under the bladder border in that region. Okay, so the CSD can be identified by transvaginal sonography. Okay, now this is just a sample, no, of your ultrasound picture showing you the uterine niche. As you see, there's also the destruction already. Dito, oh, ang laki na niya. No, severe cesarean scar deficiency, more than 50% of the myometrium at the scar level. Okay, ito naman a thin linear defect. Okay, now this one is in relation to the fetal head. The thickness and the thinness of the lower uterine segment in relation to the fetal head. Okay, of course, another part or plan of the management will be delivery. Okay, timing of delivery is very important. Okay, because you don't want your patient to really mag-contract sa bahay that could lead eventually to uterine rupture. Okay, so according to our Williams 26th edition, it recommends delaying non-medically indicated deliveries until 39 completed weeks, gestation or beyond. Okay, so accurate pregnancy dating using a combination of last menstrual period and sonography is very important. Okay, most accurate method to confirm is by crown rump length during the first trimester. Okay, so Williams labor induction is associated with a higher total labor rate compared with spontaneous labor. Okay, so use of oxytocin for labor induction or augmentation has been implicated in an increased uterine rupture in women undergoing TOLAC. Okay, wala siyang nilagay sa Williams na absolute contraindication except for misoprostol. But in our POG CPG, okay, they do not recommend prostaglandin for cervical priming in patients with prior cesarean delivery. Okay, also, labor induction or augmentation is not recommended in patients with prior cesarean delivery. Okay? So, after the plan of management, then you can tell your patient that she can observe for onset of uterine contractions. Okay? Remember that spontaneous labor ang pinakamaganda for higher success rate for patients with previous cesarean scar na gustong mag-VBAC. Okay, but again, you have to have shared decision-making skills. You have to counsel your patients.
Pero hindi
And
po nasimula.
she has to be aware of her
Kasi
symptoms.
pagkalabas ko lang.
Okay, kasi nga minsan, lalo na pag mataas ang tolerance of pain ng pasyente nyo, hindi nila alam yung contractions. Okay? So this one is just from our COG, but I'm not gonna expound on this already because you might get confused. No? Basta what we is for priming and for cervical induction.
Tsaka hawak
It's
na
not
niya yung
recommended. Okay? So question number 8. A patient is at the DR for tulak and suddenly complained of severe epigastric pain associated with a non-reassuring fetal heartbeat. So, what is the next step? Okay,
Saan na yung endorsement?
Congrats. Naway magkakaroon ng dysuria.
Let's learn by lesson. The hard way. Bye-bye.
Saan yung endorsement?
Try.
Eh, paano nga yung mga check hawak na ng nurses? Bedside.
Ay, sorry, what's... Sige.
Nalipat
So, rupture versus dehiscence, when we say rupture, it's a clinically significant uterine disruption which can be defined as a complete disruption of all uterine layers, including the serosa. Okay? If it's uterine dehiscence, refer to a clinically occurred uterine disruption or uterine window, which can be loosely defined as an incomplete disruption that is not readily discernible by signs or symptoms and does not lead to any serious maternal or neonatal consequences. Okay? It is often discovered incidentally at a cesarean birth. Okay? So, question number 9. What is the most common fetal heart rate pattern seen in uterine rupture of a patient during tulak? Okay, let us look at the answer. Letter B. It's prolonged fetal bradycardia. Okay? That will eventually lead to progressive yan, of course, from a non-reassuring to variable decel, into late decel, and fetal bradycardia. Okay, other symptoms will include a mirroring of placental abruption with little appreciable pain or tenderness, loss of station by pelvic examination, vaginal bleeding. Medyo kailangan maingat tayo with regards to vaginal bleeding as a sign, no? Because syempre, your patient is in active labor. They could also be bleeding
Mandadagdagan pa
talaga.
daw sa August.
Hematuria, okay? Hemodynamic instability, which are already late signs of uterine rupture and changes in contraction patterns. Okay, so this one is just a diagnostic picture of uterine rupture based on clinical signs and symptoms and ultrasound findings. Okay, according to the article on American Journal of OBGYN in 2024. So in clinical signs, you have your abnormal fetal heart rate tracing, either deceleration or prolonged fetal bradycardia, abnormal contraction, acute onset abdominal pain, epidural dose escalation. So meaning for patients na naka-epidural, no, because it's not naman an outright or absolute contraindication to epidural. Those who keeps on requesting for epidural, baka sign na yun. Okay, vaginal bleeding, again, loss of fetal station, and the likes that I have mentioned. For ultrasound findings, there could be expanding hematoma overlying or adjacent to the hysterotomy scar, fetal membranes protruding beyond the uterine wall, free fluid in the maternal abdomen. No? So this one are actually late already. So you don't naman, if you suspect uterine rupture, immediate delivery na agad yun. you don't go to an ultrasound pa. Okay, but sonographics can be done, no? Pero hindi naman natin nagagawin yan. Okay, because that's scary. Identification, like what I've mentioned na kanina, I have mentioned this already, no? But in laparotomy, doon na talaga natin siya makikita. Okay? Now, what's the plan of management for patients na who will go through TOLAC, no? Inside the hospital. So, stabilize the patient kapag may instability, notify the anesthesia service, notify the neonatology service, and of course, prepare for unexpected findings. Okay, midline incision is preferred, especially if hematoperitoneum is suspected, because you want a good exposure of the uterine fundus and for comprehensive abdominal exploration. Okay? So, for uterine rupture, syempre, delivery of the baby na ang ating plan of the management. Okay? Ang question lang is, are you going to repair the uterus or are you going to do hysterectomy? Okay? So, for the repair of the uterus, the goal of management is to control the hemorrhage, identify damage to other organs like your urinary tract, and then minimize early post-surgical morbidity and reduce the risk of complications in future pregnancies. Okay, and what are complications that we can usually expect acutely? The atony and the bladder trauma, as well as pelvic organ injury, and also the occurrence of placenta acquita spectrum on the next or succeeding pregnancies. Okay? So question number 10, after delivery of the baby, there was a difficulty in removing the placenta. Blood pressure is 80/50, tachycardic, and the uterus is noted to be bulgy. Okay, so what is the next best step? Madali na lang to, no? This is letter C. Okay, proceed with hysterectomy. Okay, so that is a case of a placenta acquita spectrum. Okay, wherein a placenta acquita spectrum is defined as an abnormal adherence, okay, or aberrant presentation characterized by abnormally implanted, invasive, or adhere placenta. Okay, this abnormal adherence stems in part from partial or total absence of the residuo basalis and imperfect development of the fibrinoid, or what we call the Nittabooks layer. Okay? Now, there are variants of our PAS, or placenta acquita syndrome. You have your placenta acquita, wherein the villi are attached to the myometrium. We have your increta, wherein the villi invades the myometrium. And you will have your percreta, wherein the villi penetrate through the myometrium or through the serosa already, even penetrating the bladder. Okay? Now, how do we diagnose? Okay, for our patients na may first trimester or second trimester bleeding, pwede siya, especially on the background of a previous cesarean delivery, pwede kang mag-suspect ng first and second trimester bleeding. Okay? For sonographical evaluation, we can also do that, especially with lesser bleeding during the first trimester. We can measure the smallest myometrial thickness, which can predict, okay, the possibility of PAS, no? But better, okay, the 5 characteristic sonographic findings, which includes a presence of placental lacunae, thinning of the retroplacental myometrium, disruption of the bladder-uterine serosal interface, bridging vessels, and placental bulge that pushes outward and distorts the contour of the uterus. Okay, so you can see that. Okay, now this one is from Tillind's Operative Gynae 12th edition in the management of PAS. Criteria for classification of Acquita Centers of Excellence and Guidelines. No? So you have to have a multidisciplinary team, an experienced maternal and fetal medicine physician or OBGYN, imaging experts for your ultrasound, pelvic surgeon, no? Especially gyne-onco and urogynecologists to repair the bladder if there is invasion for difficult surgery, anesthesiologist of course, urologist, okay, if there is bladder tear or there is a need for repair, trauma or general surgeon, interventional radiologist, and neonatologist. Okay, now the intensive care unit or facility should have a surgical and medical intensive care unit. Okay, a 24-hour intensivist availability. No? And for blood services, you have to have a massive transfusion protocol in place. Okay, experience and access to alternative blood products dapat meron din, and guidance of transfusion medicine specialist or blood bank pathologist. Now, what will be your criteria for consideration of the delivery in Acquita Center of Excellence? No? Suspicion for placenta acquita on sonogram, previa with abnormal ultrasound appearance, or placenta previa with more than 3 prior cesarean deliveries, history of classical cesarean delivery in anterior placentation, history of endometrial ablation or pelvic irradiation, inability to adequately evaluate or exclude findings suspicious of placenta acquita, and any other reason for suspicion for placenta acquita. These are the criteria for consideration of the delivery in Acquita Center of Excellence. Okay? Now, with regards to uterine preservation and expectant management, uterine preservation is defined as a conservative management or removal of placenta or uteroplacental tissue without removal of uterus kapag kaya. Okay? And expectant management is leaving the placenta either partially or totally inside too. Okay? Now, for conservative management, occasionally, it may be possible to trim the umbilical cord and repair the hysterotomy. This is according to our Williams. Repair the hysterotomy incision, leave the placenta inside too, and not pursue hysterectomy. Okay? However, this option is used only for women in whom abnormal placentation was not suspected, meaning andun na, okay, and you are not prepared, and in whom uterine closure can stop the bleeding. After this, she can already be transferred, okay, to a higher level of care na facility for definitive management. Okay, or another consideration that we can think of is a woman with a strong desire for fertility and who has received an extensive counseling. Okay, so resection of the adherent placenta and underlying myometrium has been advocated as a uterine sparing technique. Okay, and when the placenta is retained, ang average resolution niyan is about 6 months. Okay? But dun sa Williams natin, nakalagay doon, American College of OBGYN in 2018 says that leaving the placenta inside should be considered investigational. Okay? Exceptions are those when you want to transfer your patient to a higher level of care. Okay? How about, Doctora, the use of methotrexate? I did not see any dosing or paano but also the toxicity of methotrexate. Yun din ang problema. So it's actually not recommended sa Williams. Okay? Now, sa Telins, meron silang algorithm, okay, in approaching a patient na may placenta acquita syndrome. Okay? If lalo na precrita, specifically ito. Intraoperative findings is suggestive for precrita. There is distorted or distended lower uterine segment. The blood vessels is visible on the uterine serosa, and there is placental invasion into the bladder or surrounding tissues. Okay, if there is no bleeding, the patient is stable, as well as the fetus, and facility is not prepared, then do not attempt. Okay, you should stop, cover the uterus with warm laparotomy pack, and await assistance and supplies before proceeding with hysterectomy and operative intervention. Or, close the fascial incision, place staples in the skin, and consider transfer to a tertiary facility with experience in management of pregnita. Okay, so meaning walk-in patient, nasa district hospital ka na hindi masyadong capable, tapos biglang pagbukas mo mukhang percrita, okay, by your clinical eye, so might as well stop. Okay, now if there is active bleeding and the patient is unstable, apply local pressure to the bleeding areas, prepare for hysterectomy and delivery, followed by the definitive management of placenta percrita. Okay? So now, since may uterine rupture, tapos may akrita na ang ating trust ng topic, of course, hysterectomy na ang sagot dyan. Okay? Now, as defined, no, hysterectomy is the most commonly performed to arrest or prevent hemorrhage from intractable uterine atony, surgical traumas, or abnormal placentation. Okay? So, dapat walang patumpik-tumpik, mabilis. No? Dapat kapag if you feel that kailangan mo na siyang i-hysterectomy, then wag ka nang mag-isip. Okay? So, kaya nga sa counseling natin, di ba, you have to always include the possibility of hysterectomy in your informed consent pag nga mga PAS ang kaso mo. No? Ang question lang dyan is whether you do total hysterectomy, which is more common, or supracervical hysterectomy. Okay? Or subtotal hysterectomy. Okay? Now, what are the indications for your peripartum hysterectomy? You have, again, your uterine atony, abnormal placentation, uterine extension, rupture, cervical laceration, postpartum uterine infection, leiomyoma, invasive cervical cancer, and ovarian neoplasia. Okay? That's for peripartum hysterectomy. Now, for surgical technique in PAS, if you will do peripartum hysterectomy for suspected placenta acquita, again, this is from Telin's operative gyne, no? Delivery is scheduled typically at 34 to 36 weeks age of gestation. Consideration should be given to placement of vascular catheters for embolization or balloon exclusion preoperatively if heavy bleeding is expected. And then, of course, in a lithotomy position and vascular access established, all available stopping and blood products should be available prior to the procedure. Cystoscopy with placement of retrograde ureteral stents can be considered. Laparotomy and hysterectomy are performed away from the placental bed. Hysterotomy site is closed without disruption of the placenta and the placenta left inside too. And then the retroperitoneal space are opened after closing the uterine layers. The uterovarian ligaments are divided and the cardinal ligaments is dissected to the uterine arteries. And then the vesicouterine peritoneum is opened and the bladder mobilized away from the uterus. And then you proceed with your hysterectomy already. No? The uterine arteries are divided. The uterus is placed on traction. And the cervix and the remainder of the lower uterine segment are removed and vaginal cup is closed. Okay? Now, if ever on opening up, no, emergent peripartum hysterectomy ang tawag doon. Yung kapag bukas mo, walk-in patient, di mo alam na placenta acquita, no? By definition, emergent peripartum hysterectomy is most often required in women with uterine atony or undiagnosed placenta acquita. Okay, when atony and bleeding persist despite conservative measure, one should urgently already proceed to hysterectomy. Okay, and these are the procedure. Okay? So, dapat meron kang obstetrical hemorrhage protocol activated already. Additional vascular access. Siyempre, call for help ang unang-una, no? A rapid assessment to determine the source of bleeding. Okay? If the source of bleeding is due to atony, you can do conservative uterine sparing techniques. But, if the source of bleeding is felt to be due to a placenta acquita, the surgical team should rapidly proceed to hysterectomy. Okay, if necessary, the patient should be intubated and GA induced to facilitate the procedure, and then proceed already with your hysterectomy, given this following surgical techniques. Okay? The uterus is amputated, either total or subtotal hysterectomy, depending on the status of your patient. Okay, so these are my references. Tapos na ako, Sir Ross, mas maiksi on this topic.
Thank you very much, Doctora. We'll just Check lang. Actually, may naka-raise ng hands, but I don't know if they have questions. Dr. Jenica, you have question po? You can post it in our Q&A. Dr. De La Rosa, if you have questions po, you can post it in our Q&A po. Nag-lower yung hand kasi. I think wala naman sa akin, Doktora. They lowered their hands na.
So thank you so much everyone for attending this BSB-initiated RISE review. So see you again on the day 2. Hindi na pala ako yun.
Yes.
Ibang Zoom link pala, sir, no?
Yes po. I'll just post na lang the Zoom invitation and link, Doktora.
Okay, thank you so much,
Thank
sir.
you very much, Doktora
Thank you.
Malimits.
Thank you, Doctor.
Thank you,
Maraming
sir.
salamat
Thank you
po.
po.
Yes, and for all the delegates, Doctor, please wait for the QR link and the registration link from our BSB sales personnel from your different territories po. Kami po ulit yung magsasend ng link. Thank you.
Thank you. So see you again on August 10. That's our second day of our review with infectious lectures by Dr. Jennifer Kong. So thank you.
Recording stopped. Pregnancy is a profound journey of transformation and joy in a woman's life. A time to celebrate milestones and embrace the powerful changes unfolding within her. Protecting both lives begins with prioritizing health. Nourishing both mother and child is the foundation of vital development. Key nutrients help safeguard against serious concerns, like neural tube defects. Luckily, much of the NTD burden is preventable. Starting folic acid before conception and continuing through pregnancy is vital. But did you know there's a more superior form of folic acid? A readily utilized form of this crucial vitamin. Introducing Foladvance with 5-methyltetrahydrofolate, the active form of folate that the body can use immediately. Unlike regular folic acid, it does not require conversion in the body, making it ideal for supporting a woman's health even before pregnancy begins. Foladvance, your partner in nurturing life, optimal nutrition, and expert care. Because sometimes knowing you're giving more than enough is what gives you the courage to begin. Celebration of being a woman is easy if nothing is holding you back, like pain, especially if that pain is oftentimes misunderstood. Symptomatic impact of endometriosis affects millions of women with delayed diagnosis, since most conditions do not have noticeable symptoms in the early stages. Help is on the way as we introduce Dianogest Evifact, an oral treatment formulated to help reduce hormone production linked to painful symptoms of endometriosis. There is now a treatment option for long-term management of life-hindering endometriosis-associated symptoms. Dianogest Evifact, ending endometriosis pain, 1 tablet daily. Every woman's journey is different, but every woman deserves support that's backed by science and rooted in care.
At BSV Bioscience Philippines, we are serious with our mission of bringing life to life. One of the therapy area of focus of BSV is women's health. So this explains a great deal of our understanding of womanhood and motherhood. We ensure our products like Evifact or Dianogest and Fall Advance are not only scientifically backed, but accessible, high quality, and economical, especially for Filipino women.
From healing to hoping, there's 2 new reasons to celebrate brighter beginnings. Dianogest Evifact, your daily dose of endometriosis relief, and 5-methyltetrahydrofolic acid, Fall Advance, ensuring a safe mommy and a healthy baby. Let your journey continue with care you can trust. Dianogest Evifact and 5-methyltetrahydrofolic acid, Fall Advance. From BSV Bioscience Philippines Incorporated, supporting women's important journeys, lighting the way forward.
Life is a journey where each stage of life comes with escalating curiosity and excitement, with increasing stamina and vigor. As we age, we experience different health challenges that may lead to pain and anxiety, impacting our quality of life, so much so that it disrupts our daily activities altogether. It has been qualified that 1 in 10 women suffer from endometriosis, a significant health problem that may lead to infertility, which also causes severe physical and emotional pain. Men, on the other hand, are at risk of having prostate cancer, the 3rd most common cause of cancer death in the Philippines. BSV Bioscience Philippines is your partner in helping your patients relieve the pain of endometriosis and manage your patients with prostate cancer with our leuprorelin acetate, Luprodex. Luprodex, BSV's brand of leuprorelin acetate, is a GnRH agonist that is proven to decrease pelvic pain and ease endometriosis in women. Luprodex is also used in the management of prostate cancer. Luprodex is a slow-release injection that works to treat prostate cancer by reducing levels of testosterone to slow down the growth and spread of the cancer. BSV's leuprorelin Luprodex employs a microsphere-based delivery system and is available in 3.75 milligrams and 11.25 milligrams depot formulations, which releases the drug in a graded fashion. Luprodex 3.75 milligrams degrades over a period of 1 month, while Luprodex 11.25 milligrams degrades over a period of 3 months. Luprodex is backed up by BSV's more than 50 years of pharmaceutical experience. It is produced and manufactured in our state-of-the-art facilities in Germany to ensure safety, efficacy, and quality. Luprorelin acetate, Luprodex, promotes better efficacy due to consistent plasma levels, drug stability inside depot formulation, and improves patient compliance. Luprorelin acetate, Luprodex 3.75 and 11.25 milligrams are now available. Ask your BSV representatives for more details.
Every pregnancy is unique, and although every expecting mother's aspiration is to have a healthy and stress-free pregnancy, complications often occur that sometimes lead to a stressful process. Based on World Health Organization, there is an estimated 13.4 million babies born preterm in 2020, and preterm birth complications are the leading cause of death among children under 5 years of age. It is our role to support our patients have a healthy and smooth pregnancy. That is why it is important for us to have a reliable, safe, and natural product to help our patients through their journey. Giving oral progestin will help normalize the progesterone level in the body to assure an on-time delivery in pregnant patients and improve menstrual cycles of non-pregnant women. Progesterone is our natural solution to help women reduce the risk of pregnancy complications such as threatened abortion and preterm labor. Progesterone is natural, making it safe not only for pregnant women, but also for women trying to conceive by preparing the uterus for pregnancy. Progesterone, when micronized, provides easier absorption, thus promoting higher efficacy. BSV Bioscience is committed in bringing light to life by providing our partners a solution to our patients' needs. Started in 1971, BSV is backed up by 52 years of experience in the pharmaceutical industry. Each produce is meticulously checked and reviewed to ensure that our offering is of great quality, giving you a wide range of products for women's health and fertility since 2018. It is our pleasure to introduce to you the newest product of BSV, Micronized Progesterone Myprogen. Progesterone Myprogen is
natural,
making it safe for your patients,
micronized,
for improved absorption and efficacy,
economical,
promoting more patient compliance. Micronized Progesterone Myprogen, now available from BSV Bioscience Philippines.
So thank you. See you again on August 10 for our second day of our rice review. And to remind you, we will be sending you the new Zoom invitation and link from our BSB representative. Thank you.
is a profound journey of transformation and joy in a woman's life. A time to celebrate milestones and embrace the powerful changes unfolding within her. Protecting both lives begins with prioritizing health. Nourishing both mother and child is the foundation of vital development. Key nutrients help safeguard against serious concerns, like neural tube defects. Luckily, much of the NTD burden is preventable. Starting folic acid before conception and continuing through pregnancy is vital. But did you know there's a more superior form of folic acid? A readily utilized form of this crucial vitamin. Introducing Foladvance with 5-methyltetrahydrofolate, the active form of folate that the body can use immediately. Unlike regular folic acid, it does not require conversion in the body, making it ideal for supporting a woman's health even before pregnancy begins. Foladvance, your partner in nurturing life, optimal nutrition, and expert care. Because sometimes knowing you're giving more than enough is what gives you the courage to begin. Celebration of being a woman is easy if nothing is holding you back, like pain, especially if that pain is oftentimes misunderstood. Symptomatic impact of endometriosis affects millions of women with delayed diagnosis, since most conditions do not have noticeable symptoms in the early stages. Help is on the way as we introduce Dianogest Evifact, an oral treatment formulated to help reduce hormone production linked to painful symptoms of endometriosis. There is now a treatment option for long-term management of life-hindering endometriosis-associated symptoms. Dianogest Evifact, ending endometriosis pain, 1 tablet daily. Every woman's journey is different, but every woman deserves support that's backed by science and rooted in care.
At BSB Bioscience Philippines, we are serious with our mission of bringing life to life. One of the therapy area of focus of BSB is women's health. So this explains a great deal of our understanding of womanhood and motherhood. We ensure our products like EvaFact or Dynagest and Foladvance are not only scientifically backed, but accessible, high quality, and economical, especially for Filipino women.
From healing to hoping, there's 2 new reasons to celebrate brighter beginnings. Dianogest Evifact, your daily dose of endometriosis relief, and 5-methyltetrahydrofolic acid, Foladvance, ensuring a safe mommy and a healthy baby. Let your journey continue with care you can trust. Dianogest Evifact and 5-methyltetrahydrofolic acid, Foladvance. From BSB Bioscience Philippines Incorporated. Supporting women's important journeys, lighting the way forward.
Life is a journey where each stage of life comes with escalating curiosity and excitement, with increasing stamina and vigor. As we age, we experience different health challenges that may lead to pain and anxiety, impacting our quality of life, so much so that it disrupts our daily activities altogether. It has been qualified that 1 in 10 women suffer from endometriosis, a significant health problem that may lead to infertility, which also causes severe physical and emotional pain. Men, on the other hand, are at risk of having prostate cancer, the third most common cause of cancer death in the Philippines. BSV Bioscience Philippines is your partner in helping your patients relieve the pain of endometriosis and manage your patients with prostate cancer with our leuprorelin acetate, Luprodex. Luprodex, BSV's brand of leuprorelin acetate, is a GnRH agonist that is proven to decrease pelvic pain and ease endometriosis in women. Luprodex is also used in the management of prostate cancer. Luprodex is a slow-release injection that works to treat prostate cancer by reducing levels of testosterone to slow down the growth and spread of the cancer. BSV's Leuprorelin Luprodex employs a microsphere-based delivery system and is available in 3.75 milligrams and 11.25 milligrams depot formulations, which releases the drug in a graded fashion. Luprodex 3.75 milligrams degrades over a period of 1 month, while Luprodex 11.25 milligrams degrades over a period of 3 months. Luprodex is backed up by BSV's more than 50 years of pharmaceutical experience. It is produced and manufactured in our state-of-the-art facilities in Germany to ensure safety, efficacy, and quality. Leuprorelin acetate, Luprodex, promotes better efficacy due to consistent plasma levels, drug stability inside depot formulation, and improves patient compliance. Leuprorelin acetate, Luprodex 3.75 and 11.25 milligrams are now available. Ask your BSV representatives for more details.
Every pregnancy is unique, and although every expecting mother's aspiration is to have a healthy and stress-free pregnancy, complications often occur that sometimes lead to a stressful process. Based on World Health Organization, there is an estimated 13.4 million babies born preterm in 2020, and preterm birth complications are the leading cause of death among children under 5 years of age. It is our role to support our patients have a healthy and smooth pregnancy. That is why it is important for us to have a reliable, safe, and natural product to help our patients through their journey. Giving oral progestin will help normalize the progesterone level in the body to assure an on-time delivery in pregnant patients and improve menstrual cycles of non-pregnant women. Progesterone is our natural solution to help women reduce the risk of pregnancy complications such as threatened abortion and preterm labor. Progesterone is natural, making it safe not only for pregnant women, but also for women trying to conceive by preparing the uterus for pregnancy. Progesterone, when micronized, provides easier absorption, thus promoting higher efficacy. BSV Bioscience is committed in bringing light to life by providing our partners a solution to our patients' needs. Started in 1971, BSV is backed up by 52 years of experience in the pharmaceutical industry. Each produce is meticulously checked and reviewed to ensure that our offering is of great quality, giving you a wide range of products for women's health and fertility since 2018. It is our pleasure to introduce to you the newest product of BSV, Micronized Progesterone, MyProgen. Progesterone Myprogen is
natural,
making it safe for your patients
micronized,
for improved absorption and efficacy,
economical,
promoting more patient compliance. Micronized Progesterone Myprogen, now available from BSV Bioscience Philippines.
close the Zoom na po. Again, see you on August 10, 8 o'clock to 12 noon. Thank you.